It's Bill Storms, and I want to talk today about the Allergic March, from eczema to asthma, charting and predicting this path. So what is the Allergic March? It's very oversimplified, but it's the natural history of pediatric atopic disease. Concept is the skin barrier disruption in infancy drives early Th2 sensitization that later manifests in the gut, then in the nose and the lungs. So it starts with the skin, with atopic dermatitis. 13% of 1-year-olds have AD, 20% of 2-year-olds have AD. Then the sensitization goes to the gut, and food allergy is present, most commonly egg and milk in infancy. Then into the nose with allergic rhinitis, which is usually preschool, then asthma, school age onward. So let's look at the prevalence of these various things. Atopic dermatitis by age 1, 13%, by age 2, 20%. Eczema prevalence in childhood in general, 15 to 30%. Asthma, as you know, is a global issue. That's very prevalent. And allergic rhinitis in adolescents is about 21%. This is a schematic of the so-called Allergic March. We have prevalence on the vertical and age on the horizontal axis. So we have the dark blue, which is atopic dermatitis, prevalent in youngsters, age 0 to 1 to 2. Then by age 3, 4, 5, the prevalence is reduced significantly. Next, let's look at food allergy, which is green, a little more common in youngsters than the later years. Next, let's look at asthma, because that's obviously the most dangerous of all these. It has a steady increase from birth until age 5 or 6, and then it levels off. And then allergic rhinitis starts to increase about age 3, and then it keeps increasing at age 10, 15, and into adulthood. So the so-called march is really not a march. It's a heterogeneous trajectory. It's not one fixed sequence. So 1 in 4 children with eczema go to one or more other allergic phenotypes. 1 in 5 children with eczema will transition to full multi-morbidity, atopic dermatitis, asthma, and rhinitis. There are 8 distinct atopic trajectory profiles that have been identified in this analysis of over 9,000 children. So some go from eczema to asthma, some go from allergic rhinitis to asthma, etc. On the right, there are certain caveats from this NIH workshop that this really should not be a march. It should be atopic multi-morbidity. However, that doesn't quite have the catchy phrase. Most children never follow the classic food allergy, allergic rhinitis, asthma direction. Some develop wheeze or rhinitis before any skin disease. Many with early eczema resolve completely, and so the timing, the organ involvement, and the severity all vary widely from child to child. So how often does one allergic disease predict the next? So the vertical axis are the odds ratio for having asthma on the left if you have a child with early eczema. So with early eczema, 3 times risk of asthma and a 5-year follow-up. 3 times risk of allergic rhinitis. So you can see that eczema is really driving all this. So how do we predict the next step in a given patient? There are 4 general categories of evidence that help us decide which infants will progress. One is genetic. The filaggrin protein, I'll talk about in a minute, which is a skin barrier issue. The clinical phenotype, do they have early onset, severe persistent eczema? That's a major. Immunologic, are they polysensitized, so the number of skin tests and or blood tests for IgE in the young children, and these could be foods or pollens or molds or animal dander, and the family history, atopic parents, especially the mother. So let's look at early onset severe asthma. That's the first predictor. So it's the single strongest clinical predictor of the atopic march. So on the vertical axis we have the percent of asthma in kids who have early onset persistent eczema, 31% with asthma at age 13. If they don't have early onset persistent eczema, 7% of asthma at age 13. So what makes you suspicious? What can you tell the parent when they ask questions? Onset of eczema before age 6 months, moderate to severe body surface involvement, persistent beyond the toddler years rather than getting better, poor response to the standard therapy, and concurrent food sensitization. So bad asthma, continuing to have it, and food allergy. So let's talk about predictor number 2, the filaggrin protein. So a leaky skin barrier is a gateway to allergic sensitization. Filaggrin protein aggregates keratin in the skin's outer layer, forming the barrier that locks in moisture and blocks allergen entry. So those people who are filaggrin null mutation, they don't have filaggrin. That's about 7 to 10% of the population, but 50% of patients with moderate to severe atopic dermatitis lack that protein. However, 40% of carriers never develop eczema, so genotype alone does not predict the outcome. So the idea is there's this loss of function of the skin, impaired skin barrier function, and the allergen exposure is on the skin. So it's food, allergens from the air, dander, mold, whatever it may be, and that stimulates Th2. And then the sensitization spreads to the gut with food allergy, the nose, allergic rhinitis, lungs with asthma. So on the bottom left, the odds ratio for young kids who do not have the filaggrin protein, 6 times for asthma plus eczema, 5-time odds for allergic rhinitis plus eczema, 3x for just allergic rhinitis alone. The carrier frequency is 25% in the asthma plus eczema subgroup versus 20% for allergic rhinitis and eczema. The allergic rhinitis is independent of eczema, is a 10% risk, and asthma alone without eczema showed no association, so eczema is the entry point for all of these. Predictors number 3 and 4, the sensitization burden and the family history. So the number of positive allergens by age 2 or 3 correlates strongly to later asthma risk. Children who have multiple food and air allergens are more likely to develop respiratory allergy disease. And early egg and milk sensitization specifically flags that elevated risk for rhinitis or asthma. Family history is important. A family history of asthma or atopic disease. Maternal atopy is the most important rather than paternal. So the family history with the child's own eczema and the sensitization is a stronger signal. These are some validated prediction tools. I don't want to go in too deep, but there's an asthma predictive index, which basically I think is primarily used in research studies. For instance, recurrent wheeze in the first 3 years plus 1 major or 2 minor criteria. That would be physician diagnosed eczema, aeroallergen sensitization, eosinophilia, wheezing other than colds, food sensitization. Now, you could use these in a patient, and you could give the parent some idea as to what the likelihood ratio over on the right. If they're positive on this, the likelihood ratio of asthma is 7 times. There's the modified asthma predictive index, same thing, except they have to have 4 wheezing episodes a year. That raises the probability of asthma to 90%. So you can use that if you like. There's the pediatric asthma risk score from the Isle of Wight. It has multiple factors, and you'll see here the sensitivity of the Isle of Wight score is 0.67, specificity is 0.79. For the modified asthma predictive index, the pre-test versus post-test, if they are positive, they have a 90% chance of having asthma. But again, it's not 100%, and so if you tell a parent that the child's going to have asthma, that might be a concern of the parent, unnecessary concern. So it's something you could use if you like, but it could have drawbacks. So here's the asthma march. We're seeing patients who have eczema, they have allergic rhinitis. Can we change this? So realize our opportunity, this is a modifiable trajectory. It's not a fixed fate. The first thing is early allergen introduction. We know that early peanut introduction substantially reduces late peanut allergy development. There's also skin repair. So there are a number of studies looking at these daily emollient trials in these high-risk newborns, and I'll show you a little of that in a minute. But by itself, it didn't really change anything. There are 2 studies, BEEP and PREVENT et al. However, biologic therapy with dupilumab, Dupixent, this is an observational study, but it showed that it has significantly reduced asthma by 40%, allergic rhinitis by 31%, no effect on food allergy. So these are the skin barrier prevention trials. The BEEP is the UK study, over 1,000 high-risk newborns. They had daily whole body emollient for 1 year. Now that's really something. I'm not sure how many parents would be able to do that. And there was no reduction in eczema at age 2. So that study didn't do anything. There was a little more in skin infections in those kids who used the emollient, and there was no signal towards more food allergy. The PREVENT et al. Study, Norway, Sweden, 2,400 newborns. They had a multifactorial design. They had skin emollient and early food introduction, and that was crossover. So they showed that the skin emollient alone did not reduce atopic dermatitis at 1 year, but early food introduction, and it was up here egg, milk, wheat, peanut, did reduce food allergy at 3 years. So the skin emollients aren't doing much, food introduction does. So here's the study that was observational on dupilumab to treat youngsters with severe eczema and what their risk reduction would be in, number one, the overall March progression, food allergy, allergic rhinitis, asthma, 32%. Asthma specifically, so treating with dupilumab for atopic dermatitis very early, 40% reduction in asthma, 31% allergic rhinitis reduction. So again, observational study, need to see more of a double-blind placebo-controlled standard study, but that's very, very impressive. Now, what about treating allergic rhinitis to prevent asthma? So there are studies that are going back, over 50 years. The early studies were pretty rough because we didn't have the standard double-blind placebo-controlled ideas then, but this is a more recent study, 2007. Percent who developed asthma who were treated with subcutaneous immunotherapy for allergic rhinitis, 25%. Control, 45%. So it's an important message to patients, to parents of patients, that if they have a risk for asthma based on their phenotype, their family history, but they're just coming in for allergic rhinitis, allergy immunotherapy may change that allergic march. So on the left is the study I just mentioned, asthma 10-year follow-up, 25% versus 40%. On the right was a sublingual trial, 800 children just with grass pollen, and there was no change in the time to asthma onset. That was their primary endpoint, but the odds of having asthma was reduced by 34%. I don't know why they didn't have that as their primary endpoint. So skit or slit will reduce, for allergic rhinitis, will reduce future onset of asthma. So here are the takeaways for today. Think about this as a multi-morbidity, not a fixed march. So talk to families about elevated risk. It's not inevitable, but most kids with eczema do not develop asthma, so we have to explain that. We don't want to scare our parents, but it's a discussion. Early severe persistent asthma is the biggest clinical flag. It has the strongest and most consistent association with later allergic disease, which is allergic rhinitis and or asthma. And layer in the sensitization and the family history. So severe persistent eczema plus allergic sensitivity by age 2 or 3 plus parental atopy, then your risk is much higher. And if you want to use validated tools, there's plenty of those around. Treating the skin may be treating the trajectory, so that's the message. And emerging biologic data, so far just with dupilumab, we may have other biologics come along. That's an active area of research that gives good promise. So I have a lot of references if you like, and I thank you very much.